Benil, can you show? Can you put on the first little intro presentation? So good afternoon, everybody. I am delighted that we can start. And I am Dr. Golan, who doesn't know me, and I am the former director of the neonatal department at Soroka Medical Center and the partner in this project from 2009. And can you show the next slide? I really want to thank all the faculty who helped us put this workshop together. You will get to know them as we progress and know their names. And I did send out a short info page to make sure that everybody knows everybody. I'm also honored that we have joined us Professor Karplus in our meeting, and also some of the team from Vermont Oxford Global group from with which I work in the project in Ethiopia, and we share our experience very closely. So Mike Dunn, thank you for joining. And Danielle, she apologized this time. She is not approaching, but she will be in the next meetings. We have the vision of Professor Karplus project starting from 2009. And we started when there was not stable electricity, and we had the basic neonatal care practiced in our MBUs. And here we are now with an advanced course in neonatal care, progressing our knowledge and experience in treating sicker and smaller babies using non-invasive ventilation. Really, this partnership is an amazing, long-standing, sustainable thing that we all believe can bring to these two units to be a model unit for other neonatal MBUs in other parts of Kumasi and the whole Ghana. The ambassador of Israel sent us our blessing, and I would like you to, can you go to the next slide, please? To share her blessing. No, not this one. This is Ambassador Sufa Shlomit, and can you put on the little video of 1 minute blessing that she sent to our workshop?
I'm just going to pull it up very quickly because I have to make sure that the audio comes through also.
Okay.
Dear Professor Michael Karplus, dear Dr. Agneta Golan, dear Dr. Rita Fosu-Yeboah, dear participants in the workshop in advanced neonatal care, good afternoon. My name is Shlomit Sufa, and I'm the ambassador of Israel to Ghana, Liberia, and Sierra Leone. I'm happy and honored to send you my greetings and to congratulate you at the start of this important program. I would like to seize this opportunity to commend the doctors and nurses at the MBUs in Kumasi South Hospital and in Central Hospital for your professional and relentless work. I highly appreciate your desire to further specialize in the MBU work and to become a model to other MBUs all over Ghana. The Soroka Hospital and Ben-Gurion University teams, under the leadership of Professor Michael Karplas, have been partners with the MBUs in Kumasi South Hospital and Centreso Hospital for a good number of years. They are dedicated to this mission since 2008. As well, Mashav, Israel's Agency for International Development Cooperation in the Ministry of Foreign Affairs, has been supporting this work for many years now. We all witness the good and important results of this partnership, as the effort to reduce maternal and neonatal mortalities is an effort we all share. I look forward to learn how much knowledge you have acquired at the end of this program in 3 months' time. Israel and Ghana, we are partners for development, and we will continue to work hand in hand to create a better future together. Thank you.
Okay. So, can you hear me?
Yes, we can hear you.
Okay, so thank you for the ambassador. As today is Shabbat, Shabbat is a day that official attendance of an Israeli representative is not possible. So that's why she recorded her blessing and she will participate in the closing ceremony, which will take place at the end of this workshop. So the previous slide, actually, we now go to the business. Go to the previous slide. This is our program for today. We will have 4 presentations from Kumasi South, Centreso, CAT, and the Israeli team showing the status of the MBUs and some of the data that we have from research work done on this database. And then we have Dr. Elon Shani giving us his lecture on respiratory distress and CPAP. I will be the bad guy to try to keep us in track. We already are behind a few minutes, 15 minutes, and we hope to catch it up during the meeting. And we will try to have some questions time in between the talks. So I think we start with Kumasi South presentation, and good luck to everybody.
Agi, what I suggest until we get the presentation on is that if anyone has any questions, they can write them down in the chat section. So it will be easier to address these questions.
Okay, very good.
Dr. Rita, would you like me to share the screen, or do you want to share the screen?
Please share.
Benila, are you sharing the screen?
Yes, it should be sharing now.
Okay, so good afternoon, everyone. My name is Rita Fusuyeboa, and I'm presenting on behalf of the Kumasi South Hospital. So on this presentation, I actually focus mainly on the CPAP use in the hospital with very few additions. in the year preceding, preceding year, 2021. Next slide, please. Okay, so for the outline of the presentation, we'll have a brief description of the staff strength. We will look at the state of CPAP use in Kumasi South, some of the challenges we have encountered, and then we'll look briefly at other activities in the year. Okay. So the Kumasi South Hospital as at January 2022 has a staff strength of 23 nurses and 3 permanent doctors. For the nurses, we have 12 midwives, 8 registered nurses, 1 neonatal nurse associate, 1 pediatric nurse associate, and 1 pediatric nurse specialist. These staff are permanent in the unit, and which 3 of them are new staff that were added to the unit just this December. The 3 permanent doctors include 2 pediatricians and 1 medical officer. But on the average, every 6 months, we have 6 house officers rotating through the unit, 1 every month for 6 months. Next slide, please. So the Kumasi South mother-baby unit has basically 4 rooms. We have an intensive care unit, and as you can see in the baby, in the picture that is being shown, that is where we keep our critically ill patients, patients that require CPAP machine use, and critically ill patients that require quite a little bit of monitoring. And then we have another room where we keep babies that would need maybe extra support for oxygen and all that. And then we have what we call the kangaroo mother care room. The kangaroo mother care room is basically where we keep preterms who are stable to undergo kangaroo mother care. And then we have a 3rd room where a 4th room where we keep babies that come in with infections, babies that need to be looked at. So basically there are 4 small rooms in the unit. And then what, Daniel, could you please go back to the 4th slide? What you are seeing in the 4th slide is what the intensive care unit looks like. Next slide, please. Next. Okay. So concerning the status of CPAP use in the year 2021, the total admissions to the unit in the year 2021 was 929. Okay, but the data I'm going to present for the CPAP use is from March to November 2021. The reason why this is so is that it was in March that we began using the new CPAP forms. So the data you would see would be from March to November 2021. Over that period, the total number of admissions to the unit were 732. And out of the 732, 57 of them required the CPAP use. So that makes a percentage of about 7.8% of the total admissions requiring the use of CPAP. Next slide, please. Okay, so in terms of the type of CPAP use, we had 57% out of the 75% out of the 57 patients being on the Dimedica CPAP machine. And then 25 of them, unfortunately, had to be on the improvised bubble CPAP. The reason why this is so is that sometimes if you have 3 babies at a point in time, that all requires the CPAP use, you would definitely have to put one of them on the improvised bubble CPAP until one of the machines are free for us to put the babies on. Next slide, please. So in terms of the average length of stay on the CPAP machine, the average length of stay was 3.5 days per patient. And this, I must say, is for the babies in whom we documented the length of stay on the CPAP. The least of them spent a day on the CPAP, the least number of days spent on the CPAP was a day, while the one that stayed longest on the CPAP spent 18 days. Next slide, please. So realize that on this slide, I'm saying that the 3.5 days on the average is for those in whom we documented the number of days that the baby spent on the CPAP. So we went ahead and then we analyzed the data. And then we realized that for 42% of our babies that ended up on the CPAP, there was no documentation in our notes as to the start date and the end date. And there was, for 58% of them, there was no documentation as to the start date and the end date on the CPAP machine. But for 42% of them, we had the documentation on how, on the length of days that they have spent on the CPAP machine. Next slide. Okay, so we also looked at the principal diagnosis of the babies that were put on the CPAP. 22% we had on respiratory distress, and we had 21% also being put on the CPAP with a principal diagnosis of birth asphyxia. So for prematurity with what we would suspect to be respiratory distress syndrome, we had 10. And then some babies also premature to low birth weight. So if you put it together, it's about 18%. We had some babies with pneumonia, anemia, and stuff. And then we have other diagnoses which are really not a lot, but like one for one patient. So we couldn't have put all of them on the graph. Next slide. Okay, so we looked at the outcome of the babies that were put on the CPAP. So out of the 57 babies that were put on the CPAP, 74% improved. While they were on the CPAP, we were able to successfully wean them off the CPAP. 23% of them died, and then we referred 4% to, the Kumasi Teaching Hospital. At least for this 4% translates to 2 patients, and we are fully aware that one of them survived at Kumasi. Next slide. Okay, so we look at the challenges that we have in general concerning the use of the CPAP. One of the things we know is a big challenge for us on the unit is incomplete documentation of the CPAP form. Because even with this presentation, you would realize that we did not have complete documentation in terms of the start date, the end date. Sometimes you do not have good documentation in terms of the respiratory distress score. So generally, we see some incomplete documentation in terms of the filling of the form. And initially, we were using a folder that is dedicated to the mother-baby unit. But recently, the Ghana Health Service facilities, and they are making all the documentation electronic. And one of the challenges we've had is to incorporate the CPAP forms on what we call the LIMS. The LIMS is the system for the documentation, the electronic documentation that we have. What I can say is that they have now been able to put most of the things we had in the old folders in the LIMS, so we can directly document. But for the CPAP form, we are still struggling. We've had other challenges with other forms, that we are still talking with the team. So hopefully we'll be able to straighten these things out. And then another challenge we've had is difficulty in replacement of malfunctioning parts of the diamedical CPAP machine that we are using. Next slide, please. Binel, please, next slide. Okay, so the way forward, we intend to organize training for staff on proper documentation probably every 3 months after analyzing the forms, because I mean, we go over it, we seem to be improving, and then we lapse back on our documentation. And since we tend to have new doctors every month, at least one new doctor every month, and some new nurses coming on board now and then, it's important that maybe every quarterly we try to organize a refresher for ourselves, and then when we have new staff, we take them through. Okay, so even as at just this Thursday, we have to meet the LIMS team, and so we are sure that in the next few, maybe weeks or so, we'll be able to incorporate the CPAP form into the LIMS software. With the parts of the machine, we have not been able to identify a local engineer yet with expertise on the after-sales service of the diamedical CPAP machine. So the last time we had a problem, we actually wrote to the team. Elon had already shared their email to us, so we had to send videos of what was happening so that they could help us really identify the problem. So the last challenge we had, we sent those videos, and what has happened is that they've identified the problem and sent us an invoice. So the next best step would be to find someone good who can maybe do the servicing here for us. Okay, so this is a quick run through some of the activities in the year. So we had a World Prematurity Day celebration on the 17th of November. Altogether, we graduated 24 preterms who were 1 year corrected age. So when our preterms are discharged, we follow them up to 1 year. So you see these parents, what they have inscribed in front of their shirts is that they don't believe in miracles. They are seeing one, because this woman actually spent close to, I think, 4 weeks on the ward. So his son just graduated from the clinic 1 year, and then you see someone also in her graduation at her graduating from the class. So that was just an overview of some of the activities. We are also involved in the quality of care improvement, because you would realize that even for our babies on bed asphyxia, for the babies that we put on the CPAP machine, a chunk of them, their principal diagnosis were severe bed asphyxia with a respiratory complications. Binel, could you please go to the next slide? So we've been involved in quality of care, quality improvement, looking at our staff, trying to improve the 1 minute ABGA score to about 7 in the 6 minutes. So you would see from the first graph, the 1 minute ABGA score, which are below 3, improving to around 7. 7 is in the green zone that you see during the 5th minute. So by and large, we think that in a way, maybe our resuscitation technique is also improving. So these are, in general, some of the activities that have gone on in the year prior to this presentation. Okay, so thank you very much. This is a picture that was still taken at our prematurity graduation for our mothers and nurses. Thank you for your attention.
Thank you, Rita, for this peek into what's happening in the unit. Great work, and we appreciate all the problems that you have shared with us, and we will probably have discussions on those offline. So can we go to Ashura for the second presentation, and then we keep questions in one session so we can keep in time. Yes.
Yeah, thank you so much. So good afternoon to you all. Can you hear me?
Yes, we can hear you.
Yes, we
Right.
can.
So my name is Dr. Ashura Bakari. I'm the physician at Suntreso, and I'll present the status of Suntreso MBU. Next slide, please. So by the way of background, this is our MBU. We are admitting infants between 0 to 2 months. And our annual admission actually has been increasing. We are now getting more than 1,000 admissions. And the main causes of admission are severe birth asphyxia, preterm infants, neonatal jaundice, sepsis, and other conditions.
Ashura, we cannot hear you.
Okay, can you hear me now?
Yes.
You can hear me now. Okay.
Yes.
So I was saying we admit babies between 0 to 2 months.
Yeah,
And
we got it. We
we
got
had
this
that.
one.
Next slide, please. Next slide. Okay, so with the staff at MBU, we have 2 pediatricians, myself here and Dr. Joyce Benin. We also have a permanent physician assistant, Oboshi. We have 18 nurses. Out of the nurses, we have pediatric nurses, midwives, and general nurses. We have house officers or intern doctors who spend 6 months at our department, and there are 6. And we currently have 1 pediatric resident from the Konfanochi Teaching Hospital who is doing her rotation for 3 months. And we have 1 intern physician assistant. Next slide, please. So with our admission, you realize that Suntreso admission is going up. For 2020, we had about 1,199, but we have increased to 1,462 in 2021. With our total death, for those who were born after 28 weeks, we lost 35 babies in 2020, and we lost 37 babies in 2021. But we have a lot of problems that we think with this training, it will help us because our mortality is high for babies born below 28 completed weeks, especially those 25 weeker, 22, 23. So we had a lot of discussions with our nurses and doctors thinking of, should we actually admit extreme preemies who are born below 26 weeks? Because since our survival rate for those very tiny ones is not too good, but then we don't really know the status of the survival rate of such babies at Konfanochi. So we need to talk to Konfanochi and agreed on that. But for now, many of our mortalities are those babies who are born below 25 weeks. For those above 28 weeks, majority are doing well. We have reduced somehow referrals to Konfanochi. In 2020, we referred 33, but 2021, we referred 25. And most of these referrals are babies who need surgical intervention or a review from pediatric surgeons. We have increased the number of preterm infants admitted to the unit from 200 to 329. as well as the number of birth asphyxia from 189 to 221. So in general, the admissions at our MBU has really increased. Next slide, please. So for CPAP, we currently use 2 diamedical CPAP. They are functioning, and sometimes, like Rita said, we have to use improvised bubble CPAP because you might have more than 2 or 3 babies who need CPAP, and since we have only 2 working CPAP, other babies goes to the improvised CPAP. And the main reason of us putting babies on CPAP are those with perinatal asphyxia and then preterm babies with respiratory distress. Next slide, please. So I have the data for 2020 that we have put down and analyzed. Out of 1,199, we had 98 babies on CPAP. And out of 98, 62 of them were able to be discharged home. And then we referred 10 of them and we lost 26 of them. Those who are referred are mainly babies with congenital heart disease. Next slide, please. So this is our critical unit. Unfortunately, we have not been able to keep 1 baby per cot. Like I said, our units are becoming, as every day, becoming more crowded, because sometimes you say you don't want to admit again and somebody rush with a baby not breathing. You cannot say, go, we are not taking. So we keep on taking the babies, especially now that Confanochi to keep on saying that, oh, usually their ward is also overcrowded. So critical unit is always busy with many babies. Sometimes we can have about 9 to 10 babies in this small room. Yeah, so we usually put them on CPAP, and then those who need phototherapy, respiratory distress, jaundice, those are the main cases we keep them at our critical unit. Next, please. Yeah, so next slide, please. I'll talk about other services that the unit provides, and this is include Kangaroo Mother Care Follow-Up Clinic. We also do the follow-up clinic for 1 year for all preterm babies delivered at Suntreso. And apart from the preterm babies, we also do follow-up on babies whom we have put on CPAP and oxygen for 1 year. We usually want to monitor their milestones. So we do the clinic together with the physiotherapist so that if there is any delay in their development, we'll be able to catch it earlier and intervene. We also have some quality improvement activities. We do a couple of research at the unit, and also our unit now is served as a teaching site for the physician assistant, medical student, house officers, and now pediatric residents doing their rotation at our end. Next slide, please. So this is our Kangaroo Mother Care Clinic. We have our nurses taking their weight and also calculate their feed and see how they feed, teaching them depending on the weight of the baby. We have our physiotherapists also do the clinic with us. This is the waiting area. This is the doctor's room. And these are the 2 among the babies who graduated this year. We have one here. She was born at 29 weeks and the weight was 0.9. Here are the first weeks of her KMC clinic. And now she's about 1 year and some few months. We also have this baby who was also a preemie who graduated. So in general, our discharges from preterm, they are doing well, and majority are able to come for the 1 year follow-up. Next slide, please. So with the quality improvement, the unit have 2 teams that are doing quality improvement. And as you see, our unit is crowded. So Dr. Benin and her team decided to do a quality improvement on hand hygiene to at least try to improve the infection prevention and control of the unit. So their aim is to improve compliance of hand hygiene among healthcare staff at MBU. So they install some dispenser with a hand rub and then improvise with the hand sanitizer per every cot. So you realize we put a bottle and plasters on top. So every day the nurses are filling the the bottle to make sure that before you touch the baby, you at least clean your hands as per WHO protocol. We also do some neonatal jaundice because a part of the main causes of admission at our unit are babies who are coming with severe neonatal jaundice. So our aim again was to promote early care seeking in inborn babies with jaundice. So we introduced what we call interactive postnatal education with the maternity unit. And next slide, please. We realized that up to March 2021, we have been able to reduce the percentage of baby born in Sontreso who comes in with severe jaundice by 77.4%. And we have been able to reduce the rate of exchange transfusion for babies who are born in Sontreso and have jaundice by 67.8%. Next slide, please. So, okay, so this is, I just want to show, this is our team with the research team who currently we are doing research on severe birth asphyxia and neonatal jaundice. Next slide, please. Next slide, okay. So now is with the challenges. One of the main challenge we have is the high demand on CPAP. Like I showed, our numbers have really increased because we were in 900, then we went to 1,000. Now we are close to 1,500 admissions a year. And most of these admissions are coming with respiratory distress. So the two diamedical CPAP have really been helpful, but most of the time we have to use improvised CPAP as well. And sometimes you realize, I remember there was a time you have baby, when you put on improvised CPAP, she desaturates, but when you put on diamedical, she does well. So sometimes you have to like weigh the benefits and risks, who needs the most, and you give diamedical CPAP. Also, because of that, we also have inadequate pulse oximeter for monitoring. So you realize that if you have about 3 babies or 4 babies on CPAP, we don't have the continuous oximeter to check their saturation throughout. We don't have enough. So some of them, we still use our fingertip pulse oximeter to check the saturation, and that cannot be continuous. With the ones that we put on the Massimo, it's easy. Even when you pass by, if the baby is desaturated or having high saturation, you'll be able to regulate the CPAP to the FiO2 needed. But because the oximeters is not enough, we have not been able to do for everybody. Again, phototherapy, we have about 5 phototherapy, but we still need to pair some of them. Again, the number, we are overwhelmed, to be honest, with the number of babies coming. Another thing, this is what I also wanted us to talk a lot, is the high mortality of the extreme preemies. And we are hoping maybe by the end of 3 months, we will learn some knowledge and skills that might help us to save more of these babies, because especially those below 25 weeks. We had a lot of discussions with our nurses thinking that, what else do we need? Is it because we don't give surfactant? Is it because we don't have incubator? We don't know what is it about. And some of them can survive the first week, then from the second week, they deteriorate and die. So babies, especially those below 25 weeks, has been a big problem to us. As with the congested ward, I've talked about it severally. And then inadequate nurses. You realize our ward has 18 nurses. It is not enough for this type of work, for the workload they have. The monitoring has to be very often, and they are always on their feet. So that is also a huge challenge we have. So thank you very much. Next slide, please. Thank you.
Wow. Okay, thank you, Ashura. Really impressive presentation, and so much to talk about. And we will discuss later. So we will go now to the third presentation of Kat. Nana, if you are there.
I don't think I have the presentation for Kat.
Okay, so Kat, Anana, if you can, are you there? I cannot see you.
I'm here. I'm just
Hello,
trying
Nana.
to share.
Can you
hear me?
share your screen?
Yes. Can you hear me?
Yes, we do.
Okay. Just a minute, please.
Fantastic, we can see.
Okay.
Can you say a few words about yourself before you begin, as people know you?
Sure. My name is Nana Rekumburbi. I'm a neonatologist with Komfanoche Mother Baby Unit. Thank you. Will that be enough?
Yes, for now.
All right. Okay. So by way of introduction, we'll go through, by way of outline, we'll go through introduction, our protocol for indications for CPAP on MBU, the challenges we've been facing, adverse effects, a few successes, and then we'll conclude with some recommendations. So as of last year, the MBU on the average, we're having between 350 and 400 admissions per month. And out of this number, we had about 100 of them on the average being preterm infants. The MBU from beginning of this year is being run by 4 specialist pediatricians, and we tend to have an average of 6 residents per month. With regards to the nurses, it's difficult to tell. We have about 100 nurses for the unit, but with respect to the preterm wards, there are different nurse to patient ratios. I'll talk about that later. So talking about CPAP use, we have roughly between 7 to 8 out of every 10 preterm infants being admitted, being put on CPAP, be it the bubble diamedica or the improvised CPAP system. Now, most term infants who present with respiratory distress are put on either the improvised CPAP, the non-rebreather, or mechanical ventilation. We hardly have a term infant being put on the diamedica CPAP. So the mother-baby unit is made up of 9 subunits, 3 of which are dedicated to preterm infants. So we have the preterm NICU, which is a 15 cot capacity unit. Then we'll have the stable 1 unit. So the stable 1 ward is also a 20 cot capacity ward that admits stable preterm babies. So it's like a step down from the preterm unit. Then we have the annex. So the annex is a KMC ward, and it's a 10-bed capacity ward. So the preterm unit, or the preterm NICU, is the acute care ward where respiratory or oxygen support, mostly CPAP, is provided. So here they provide acute care. It's almost like an ICU ward for the preterm infants, and it's the first port of call for preterm infants who are freshly born. So like I said, it's made up of, we have 12 incubators plus 3 radiant warmers. It has a nurse to patient ratio of about 1:8. You are only transferred out of the preterm NICU ward if you do not require any form of respiratory support and you're clinically stable. So in terms of the CPAP machine itself, WHO donated about 10 diamedica bubble CPAP machines to us in 2018. By then, Ghana was part of a multi-country clinical trial with India, Malawi, Nigeria, and Tanzania. And we're doing the IKMC study where we're looking at the survival rates of low birth weight infants who are less than 1,800 grams by comparing. So the intervention, these babies were We had babies who were immediately being put in skin-to-skin contact with their mothers or surrogates within the first 24 hours of life, as opposed to the control arm where we would wait until the baby is clinically stable before putting them in skin-to-skin position. So currently, only 3 of these diamedical CPAP machines are functional. Functional in the sense that we are struggling to sustain getting consumables. The study ended sometime in the first quarter of last year. And since then, the responsibility of getting the consumables has been on the unit itself to buy it. The hospital hasn't been very accommodating in terms of buying the consumables for us, and the unit is struggling to sustain always buying the consumables and accessories. So for now, only 3 are functional, and then the unit itself has only 2 functional pulse oximeters as well. So for the sake of this presentation, I'm just restricting it to CPAP for preterm infants. So per our protocol, the indications for CPAP administration, basically when there are signs of increased work of breathing. So we're talking about a respiratory rate of more than 60, when the baby is grunting, when there's flaring, or intercostal or lower chest retraction, cyanosis. But generally, the commonest conditions that require us putting the baby on CPAP, be it the diamedical or the improvised respiratory distress syndrome. Then you have transient tachypnea of the newborn. Then there's congenital pneumonia as well, but moderate to severe asphyxia also tends to play a huge role in that. So challenges. Understaffing. Understaffing has been a great concern for us. Once the number of nurses tend to be very low, it's difficult for a nurse to be able to get an opportunity to go and train more in terms of going to specialize, because every time the nurse puts in a request, it's rejected on the basis that once she leaves, there won't be anybody to replace her. Then another issue is a high turnover rotation of nurses. You take your time, you train a nurse, you take her through, the skills, you do presentations, hands-on and everything. And then the next thing you hear, 3 to 6 months, the nurse has been moved to the female ward or has been moved to the surgical ward. It can be very, very demotivating. Then because of the high rotation of nurses as well, it's difficult to keep up with the training, because if you're supposed to train sometimes almost every 2 months or every month, you get a new nurse coming in. So trying to keep up with, training of these nurses can also be a bit hectic. Then another issue has been lack of technical support for routine maintenance of the machines. I mean, you would read the manual and everything, you know how you're supposed to set up the machine. But if something should go wrong, it's difficult to be able to tell exactly what is wrong. And sometimes when you call the technical team, they come, and I might sound like a cynic, but I feel like sometimes they come and make the situation worse and then they go away. But because we don't know how to fix the issues, then the machine is just left sitting there. Supply of consumables, like I've mentioned, has been a problem. Then affordability. Sometimes you get the sense that the neonatal unit is not exactly a priority in terms of, equipment. So you try to make the effort to try and get the equipment yourself. But the last I checked, one CPAP machine was between $6,000 and $18,000 US, and that can be a bit intimidating. So unless an authority comes in to help, it can be difficult to acquire it. Then majority of babies in respiratory distress end up on the improvised water bottle CPAP system, which does not heat or humidify the air that is being provided to the newborn. So based on the statistics, that means that for every 5 babies who need the CPAP, only 1 of them will end up on the bubble CPAP. Then there's the issue of sharing of oxygen ports. Sometimes we run out of oxygen ports. And because we're using a lot of the improvised water bottle system, that one is difficult to tell how much oxygen we're giving. So because you have, say, 2 or 3 babies sharing one oxygen port, you want to be absolutely sure that the baby is getting enough oxygen. So we crank up the flow to the highest level, and we have no idea what is happening to the babies in the long term. Then lack of or inadequate pulse oximeters, like I mentioned earlier. Then we also have issues with frequent interruption of power supply. So eventually the generator will kick in all right, but there are times when within a couple of minutes, the lights can go on and off about 3 to 5 times. And then eventually you put the machine back on and then it's making a funny noise. Then inefficient delivery due to malposition of the prongs. Some of our preterm babies are very tiny. So if you have, say, a 600-gram baby, even the smallest, the size 0 prongs, nasal prongs for the diamedica, it ends up being too big, or the prongs end up being too long for the nasal cavity. Then, of course, obstruction of prongs with the secretions. Challenges. So like I mentioned earlier, we have huge numbers of preterm infants. We have roughly about 100 preterm infants per month. And then at the preterm NICU, the preterm NICU is always full. So we always have at least 18 babies there. And we've been fighting the urge to pair up the babies. That was one of our promises to ourselves, that we wouldn't put more than 1 baby in an incubator. But there are times when there's the urge to do so because you have nowhere else to put them. And sometimes you're forced to reluctantly wean babies off the bubble CPAP because you have a baby who's coming, who is smaller and sicker and probably would do better on it. So either you put the baby, you change the baby who was originally receiving the bubble CPAP to the improvised one, or you look around for a baby who is less ill. Another issue is a lack of a functioning mobile X-ray. So there was a portable one, but there's been a problem with the wheels for almost about 4 months now, and we're still waiting on the hospital to work on that. So it's difficult to diagnose. If the baby suddenly starts deteriorating and going down, it's difficult to rule out a pneumothorax, which is one of the common adverse effects. So in terms of adverse effects, interruption of mother and infant bonding, delay in initiation of KMC. So the clinical trial that I mentioned earlier on, basically what came out was that if the skin-to-skin contact is started within 24 hours, it reduces mortality by it reduces mortality in the first 28 days by 12%, as opposed to 15.7% in the control arm. So delay initiation of KMCs could definitely be a huge factor for mortality. Abdominal distension, feeding intolerance, then we're using more and more oxygen. Concerns about adverse effects like ROP and BPD and necrotizing enterocolitis. Unfortunately, we're struggling to get the eye department to commit and be coming to do ROP screening for us on a more regular basis, but we're still having talks with them. Then nasal trauma. Nasal trauma has been one of our biggest challenges. It ranges from slight soreness or sometimes to mucosal erosion altogether. So this slide just shows pictures of babies who've had issues with in order to be able to create a good seal, there are times when the prongs are pressed, are forced onto the nasal septum. And by the time we realize that there's necrosis, it's almost too late. But the plastic surgeons have been great in this regard. And then they've been so far, the babies that we've sent to them, they wait a bit for the baby to put on a bit of weight, and then they do the surgeries, which have turned out great. So in terms of wins, we're having more and more smaller weight and lesser gestation babies surviving now. Ashura mentioned that they're having a lot of babies who are less than 25 weeks not surviving. I don't think that is only Suntreso. And frankly, I'm thinking that 25 weekers in our setting here, it would be, in as much as we do get some of them surviving, I think that we also need to think about the long-term effects as well. At the end of the day, when we talk about fetal viability, we're talking about the chances that the baby has a 50% chances of surviving and being able to integrate into society independently. The ones who have survived, following them long-term, invariably, there's a high risk of they having neurological impairments. The few ones that I've seen, unfortunately, I think they had intraventricular hemorrhages, and then they ended up with hydrocephalus. So in as much as we're having 25, 26 weekers surviving, I think that we also need to think about the long-term effects of that as well. Then we have nurses becoming more and more confident in handling preterm infants. Mothers are also becoming more confident in taking care of their babies because they tend to spend more time with the babies. Mortality for our preterm since 2018 has been hovering between 10 and 14%. As a matter of fact, when we did the clinical trials, amongst all the 5 countries, Ghana had the lowest mortality. Our mortality was about 10% compared to the other 4 countries that ranged between 14 and 18%. So by way of conclusion, recommendations, and way forward, there's a need for regular training of both old and new staff on the use of the machines and the care of the preterm infants. What I've noticed is that in as much as you have some of the nurses becoming very confident, you realize that sometimes they tend to take certain shortcuts. So if a new nurse comes in, you can join the old nurse in training this new nurse. Otherwise, if the old nurse has picked up certain bad habits, then definitely she ends up teaching the new one, and then the tradition goes on. Then there's a need for a dedicated team of technicians and technologists who should be assigned to the units for frequent routine checks and maintenance of the CPAP machines. Because once it breaks down, it's very difficult to repair it. And then also it's almost impossible to buy or to get the hospital authorities to buy a new one. Our attitude towards equipment maintenance, I don't know whether it's just my hospital, but I mean, it's terrible and nobody wants to take responsibility for it. I think we need to do something about that. Then strict infection prevention and control. I think that when it comes to the preterm infants, especially, there's a need for strict hand hygiene. I mean, it's the most cost-effective method there is, and it can easily kill them. Then one last thing is that KMC to be started as soon as possible, preferably within the first few hours of life, if mother is available and able. We realize that KMC encompasses a lot of things. In the study, we found out that as soon as, even within the first 2 hours of life, if you help the mother to express the breast milk, you will get a bit more. And this is all attributable to the practice of KMC. Thank you.
Thank you, Nana. Impressive, again, looking into your work in Confanoche and your presentation about the challenges and difficulties and big questions that you raised. And I hope we will have opportunity to discuss some of those during the workshop. So we are very good in time. We are going to go to the Israeli team presentation, and then we'll have some time to ask questions about the 4 presentations. As you know, from quite a few years now, data has been transmitted to the Israeli team, and it had different times with different focuses, and this data became a big source of understanding and presenting good data for policymakers, so we are able to help with this in the continued support of the units. We are just going to show, especially for the nurses and who don't know the history of what we've done, we are going to present two parts. One is Dr. Benil. He will be a future doctor. He's a medical student working with us for a while now. He will present the data collection system, and then a freshly graduated student by the name of Dana Cohen will present her research work based on this database, just a peek into it, as we have lots of data and lots of opportunities for research. But we wanted to share with you also what is done with the data that we have on that side. Nana and Ashura and Rita, we will have questions to you. I have written down a few of them, and I'm sure we will be having a nice discussion later. So Benil, please go with your presentation. Thank you.
Good evening, good afternoon to everyone. Can you see my screen? Yes, okay. So I will be talking about the data collection. Can you
We
hear me?
don't see your,
We don't see your presentation.
It's
We
still
see
Rita's
still
presentation
Nana's
on.
presentation. Nana,
okay.
can you close your presentation so we can see Benil's one?
Yes, I'm so sorry. Just a
It's
minute.
okay. It's a nice picture. We like it, but
Oh, okay. Are we good?
yes.
Is it okay
Yes.
now?
It's
Yes,
okay.
thank
It's
you.
okay.
Yeah, now you can see my screen.
Yes.
Okay, okay, perfect. So as Dr. Age mentioned, I'll be talking about the data collection just so everyone in Ghana understands what we see when we receive the files. So as a quick history, this collaboration began in 2006 between neonatologists in Ghana and Israel, and we know which two hospitals are involved, Kumasi South and Central. So before COVID, once a year, doctors from Israel would go to visit, and there were educational sessions that were done at that time. But because of COVID, we've had to adapt. And one of the very nice things that have come out of that is that we can prepare this workshop format on Zoom. And so we were able to collect data from 2019 onwards, because that's when the Diamedica bubble CPAP machines were provided. And that first year, we collected some baseline characteristics, and Dr. Dana will present the results from that because that was published. 2 years ago now, we began a second stage to quantify the characteristics of the babies who were admitted, and to see what the results were when we compared both of the hospitals in a group. So these are the forms that I have access to: the admission form, the daily notes, discharge summary, and CPAP form. The daily notes, I want to note, is one of the positive impacts that this collaboration between Ghana and Israel has developed, because prior to that, I don't think there was a very systematic way of doing the nursing charts, and now it's something that's very well organized, well maintained, and it's very efficient. And so it's good because it's promoting our patient care. So I took some of the forms that are uploaded, and you can see here, this is how the old forms look like. At Kumasi, they've transitioned out of the paper forms, but at Centreso, I believe they still have these forms. And yeah, we have the basic identification and the history of the patient, as well as the initial assessment of the patient. So as I see it, I can see a bunch of very important details, because sometimes it's not always in the CPAP forms. And so I can look at these results and understand what's happening. And another thing that's really good is the problem list is listed, and there's a treatment plan. And in this case, CPAP is mentioned. So these are the daily notes. Once again, I want to commend everyone for how thorough and how efficiently they've been filled out. As you can see, everything is done very systematically and very thoroughly. Dr. Aggie and I were talking before about how these notes can still give us more usefulness. They have more utility because, for example, if you see here, the percent of oxygen is 57.5 for a baby who's at 99, 98 saturation. And so Dr. Aggie was mentioning that as a result of this workshop, hopefully the nurses and the doctors will have better training to know when to adjust these parameters. This is the discharge summary that I see. And here you see that it's listed as CPAP. And so I know without having to read the summary, which oftentimes I do have to read the summary to understand what sort of treatment the baby had to receive. I also want to talk about missing data. This is a problem that we have often, and you see here that in the previous file, CPAP was listed here, but in this case, CPAP isn't listed. But when you read the summary, it says that the baby was kept on CPAP, and so it becomes a little problematic because as we transition from the paper files to the LIMS computerized system, we might lose data, and we don't want to lose any of the patient data. These are the CPAP forms for those who haven't seen them before. We collect a lot of different variables, basic things like the date of birth, admission, gestational age, birth weight, and the cannula. Actually, I want to note that most of the forms that I've seen, they've been on Diametica CPAP. So I found it very interesting that both Dr. Ashura and Dr. Rita mentioned that a lot of the patients are on bubble CPAP. That's the handmade version. Yeah, as you can see, there's a listing for indication of the CPAP, the specifications of the CPAP. These two data points are very critical because we can get a better sense of how the patient is being treated and the amount of oxygen that he or she is receiving. Treatment, complications, outcome, hopefully all of them are here, but a lot of them are not. So I wanted to show you how the new forms look like from that are coming from Kumasi South. Here you see this is two different forms that I smushed together, but this is the admissions and the initial assessment. Everything is computerized, very easy to read. I like it a lot. I'm very happy. Hopefully the CPAP forms can also become like this. And there's also the discharge summary. So when I have the data, I read through and I put it all into an Excel system. And this is what I see at the end of the day when I have all the data collected. You can see I don't have all the variables listed in this PowerPoint, but you saw all the variables in the forms that I showed previously. But this is a very, very good picture because the only missing data is the one here. Everything else is filled out, and it's very exciting for me because it means I have a lot of analysis that I can do. This one is empty, but that's because we're not actually collecting that data anymore. This is something that's more difficult for me to work with. As you can see, this is the birth weight, but for these babies, I have very, very limited data on the type of cannula that was used, the type of oxygen treatment, the specifications on when CPAP began, when CPAP was ended, the number of days the baby was on CPAP, on oxygen in general, the max FiO2 or PEEP. And again, I want to specify that even for like this patient, everything is there except for max FiO2 and max PEEP. And so if those can be submitted in addition to all the other data, we can do some good analysis with it. Yeah, this is very problematic because we have very basic information about how long the baby was admitted for, And oftentimes that's because I have to go through the admission notes rather than because it was listed on the CPAP forms. You heard already from Dr. Rita and Dr. Ashura about the overview. Based on the files that I have, these are the births that I've been able to track. I know that there's a discrepancy between what we see here and what was presented earlier today. But yeah, hopefully we can bridge that gap. We were collecting data from January 1st of last year to January 1st of this year. We still haven't completed all of the collection. We're waiting on forms from December, and there are also a bunch of forms that are missing along the way. So far, we have 45 babies on CPAP from Kumasi and Kumasi South, and 29 at Centreso. And as you can see, we've had pretty good numbers of files that are in the system, but I just want to encourage everyone that the files should be systematically filled out and given to the information officer so that they can be uploaded to the system, because ideally we're only talking about 10 or 20 files that are missing. This is a very basic data analysis. You can see that the range of gestational ages at birth go from 25 weeks to 41 weeks and 5 days. These are some of the baseline characteristics that we can chart. And from the 45 plus 29 that I mentioned in the previous slide, 37% of them, more than 50% have survived, 15 died, 1 was transferred, which is interesting because earlier we heard that 2 were transferred from Centreso to Confanoche, but according to what I have, only 1 was transferred, and then 19 are missing data that's pretty key to even know if the baby survived or died or was transferred. So I have my last 2 slides here now, and I just want to reiterate that the importance of full data is because with this we can reflect the true status of what's happening at the MBUs. We want to be able to reflect what is happening there so that for someone who looks at the study that's been published, they have a better understanding of what's happening, what can be improved, what are good things that have taken place. And yeah, with missing data, it's very difficult to draw conclusions about quality of care or the effectiveness of the Diamedica CPAP. It's difficult to publish. And I also want to emphasize that if you keep good patient notes, that means that it's documented for the future. And the fact that you're keeping good notes means that we know, not that we need to know, but you know as a team that you've done every single step that needs to be done for that particular patient. That's what I mean by these are good habits that can carry over into the patient's care. Finally, please fill out all the sections, keep up to date with tracking forms. That means completing them and giving them to the information officer so that he can upload it to the drive. And yeah, I would encourage everyone to just continue to keep up the good work. It's very encouraging so far what we've seen, and I hope to be even more impressed with what's happening. That's what I have. Dr. Dena is I'm gonna share her slides now.
Thank you,
Thank you,
Vinny.
Vinny.
Dana, can you go on?
Yes, Vinil is putting my presentation.
Other people, please mute the microphone. Thank you.
Thanks. Hello, everyone. My name is Dana Cohen. I recently graduated from med school in Israel, and I'm very, very happy to be part of this workshop today. What I'm going to show you in the next 10 minutes is the first example of what can we learn and what can we do with all the database that you created by documenting all the treatments that you do in the units. So I'm going to talk today about the difference between inborn and outborn infant referred to the MBUs in Kumasi. Next slide, please. So, oh, no, background, please, Benny. Thanks. So a bit about the background and the objective of the study that I'm showing. The background is that in high-income countries, inborn infants have better outcomes than outborns. Inborns are the ones who were born in the hospital where a NICU or an MBU is located, and outborn are the ones that are referred to from home or another hospital facility. The objective was to compare the outborn and inborns in the MBUs in Kumasi and see what are the differences between the two populations. Next slide, please. We did a retrospective cohort, which included over 1,000 neonates born and admitted in the MBUs in between October 2016 and October 2017. The data was collected on the maternal characteristics as well as the infant characteristics and was regarding morbidity and mortality. Next slide. Thank you. For us to understand better, in all this presentation, the inborns are presented in blue and the outborns are presented in orange. So here we can see the different distribution in between inborn and outborns in the two MBUs. We can see on the left that in Kumasi South, they had more inborns compared to Centreso. Next slide, please. This next few slides will show you some population characteristics that we were able to extract from the database. Here we're looking at the maternal characteristics. The mothers of the outborns in orange were married in higher percentage. This was statistically significant, as we can see. Next slide. We can also see that the mothers of the outborns were slightly younger, but this was statistically insignificant. On the next one, we're moving to the infant characteristic, and we can see that our inborns that were born in the hospital where the MBU is located were admitted earlier in life. And we can see that 17% of outborns were admitted only on their third day of life, which means they passed a few days before they came to the MBUs to get medical treatment. On the next slide, what we can see are the main reasons of admission. Why was the inborn or outborn admitted to the unit? So on the left, we can see the inborns. And in both of the groups, we see that in red is sepsis. Sepsis was the leading cause of admission in both groups. But some interesting difference that we found was the jaundice, in yellow, of course, was a more important reason of admission in the outborn group compared to the inborn. Next slide, please. Thank you. Here, we have two graphs. The left one is about the mortality in Kumasi's MBU, in both MBUs. We can see that inborns had a slightly higher mortality rate, but it was statistically insignificant. What we can see on the right side is what we know from literature on high-income countries or Western countries. There, we see that a lot of research has been done, mostly on preterm and very low birth preterm. Here we can see that outborns had a higher mortality rate. So this is something we see in all the literature on high-income countries, and it's very interesting for us to see that it's not the same in Kumasi. Next, please. Thank you. The secondary outcome that we checked was the total hospitalization. How long does the preterm or infant stays in the unit. Here we can see that the outborns had a longer staying. It's the mean stay of more than 5.5 days in the unit, which suggested that they needed more intense and prolonged medical care. If you want to conclude the study that I present you, the most important point is that having the data is what is giving us the option to do all the analysis, and it's crucial to promote good neonatal care. We learned so much by looking on all the data that you collected. We saw that the length of stay of outborn infant was longer compared to the inborn group. In difference from what when we see in the literature and reported in Western countries, we see that the inborn mortality rate was higher, but not statistically significant than the outborn. Another thing that we think is important for you to notice is the policy of refer to the MBUs is different, and we think that the outcome reflects it. And what is important for me to say is that I'm presenting this to you as Dana, but I'm part of a very large group, including Israeli team and a local Ghana team, which all made the efforts and is still making it to make it a paper and to learn from the data that you collected. Thank you very much for your time. And if you have any questions, please ask.
Thank you, Dana.
Benil, can you leave just a minute? Sorry, Agi, can you leave just a minute, the last slide? Because just to make a couple of things clear. I mean, this has not been published before, as Benil said, it's still on the way. But what is important for me to say that what we believe the difference in mortality, or the slight difference in mortality, is because that probably babies that are not, nobody thinks that they will survive, are not reaching the hospital. And those that are born in the hospital, they are all taken care of. So they are more likely that there are difficult cases there that eventually die. So this is probably the main reason why the difference is like it is. And again, I want to stress the last thing that Dana said. It's a very, very hard work of all the people that are involved in this data collection from the two MBUs that have been an amazing job. It is not easy to keep up collecting data like they did. So thank you all very much, and I hope we will manage eventually to publish this work. Thank you, Dana.
Thank you. Benil, can you put back the main screen? I don't believe we are exactly on time. We have about a few minutes for some urgent questions that people want to ask or comment. I would appreciate 5 minutes can be okay. Questions to the team?
Everybody's speechless.
Okay, so
can I say something?
Yes, who is it speaking?
This is Nana.
Hi, Nana. Yes.
Yes. So mine is not a question. Mine is a comment regarding the issue of the outborns not surviving as much as the inborns. One thing I've picked up from Confanochi, we've picked up there too, is that the transport state of the referrals. So sometimes they arrive and hypothermia is a big issue. You can have a baby coming and the temperature is 32.5. And we know that hypothermia is very much linked to neonatal death. So I think that the state in which the babies are referred and transported to contributes significantly to their outcome. Just wanted to mention that.
Thank you, Nana. We are going to have a session on transport, I think on on the 5th meeting or something. I hope you got the whole program, and we do have the issue of transport as a huge subject of the discussion. So thank you for making this point.
I think it would have been interesting to see what happens in Confanoche, because those babies that are transported in a very, that arrive hypothermic, we don't see them in Centreso in Kumasi South, because probably either they don't come or they go straight to Confanoche, and this is why the babies in Confanoche, the outborns, fare much worse than the one that are inborns.
Oh, okay. All right.
I would comment that some of the topics raised, like equipment problems, disposables, the limit of care, the infectious control, the congestion that is coming up, those issues are very, very hot topics that we need to approach one by one and discuss it. It's fantastic to see that there are some saturation monitors, but the need is just growing as babies are surviving and taken care of. So I think that Eilon, being now the new director of the neonatal unit in Soroka, can say that we actually deal with the same topics in a different way, but the topics are very, very similar, and they have to be approached and taken care of. Mickey, would you like to ask or comment something? Can you open your microphone?
The fact that only 3 D-Medica machines of 10 are actually functioning is very, very concerning. And the same thing, I mean, the same problems are certainly also in Suntrezo and in Kumasi South. So the service of these machines is an issue which has to be addressed. I mean, it's a catastrophe if after 2 or 3 years, this equipment isn't working anymore. And the solution one has to find a solution, which means having a technician who is in direct connection with the company, and it should be possible. I mean, you don't need to send a person from the company to Ghana, and you don't need to send somebody, I don't know, to Germany or where it is. Things can be done in a different ways, but one has to find a person who is prepared to take responsibility for this equipment. This equipment is vital, essential. You have to find a solution. So I think, I mean, we will certainly discuss it later also, but I think it's something very important. And the other thing is that if treatment is incomplete because of lack of oximeters, then one needs more oximeters, and one has to find the funding for more oximeters. From wherever it comes, it is essential. So these are 2 points which I wanted to make, which impressed me very much. And maybe not now, but at a later stage, we have to discuss it seriously.
Okay. Eilon, do you have any comments in general, questions?
No, I just agree with Mickey, and I think that we will be happy, as I wrote, to try and have a short session with Nana and see how we can improve, or I don't know, hopefully can help in improving the issues she's facing, because they've made immense progress in Confanoche, and there's altogether a progress in all Kumasi, and I think it should be kept up. But it's beyond the scope of this session right now.
Okay. In general, we said when the Diamedica was introduced, we said CPAP goes with saturation monitor, continuous monitoring. And this is how it was like designed. But as we see, there are many homemade, so much more babies are on CPAP than the number of continuous saturation monitors that we have in the units. And the homemade, it's not only that it's not keeping the temperature, but also it's 100% oxygen, which is not something that we want to use in preterm infants. So I would be very putting that into the equation, the fact that 100% oxygen is inadequate for preterm infants, and the dangers that it might produce, and as well as a need for saturation monitoring, which is absolutely necessary. We will have case discussion on this, and hopefully make each of us an advocate for babies' care, as it's important. Okay, Mike, Don, are you there? If you are there, if you have any questions.
I am here. That was very impressive, and thanks for sharing. I'm just trying to take in what you're saying and get an idea of what you're dealing with, and kind of some comparison with what we were experiencing in Ethiopia. I think firstly, the results are quite impressive in terms of your survival rates and the way you've organized your teams, your documentation, and the feedback and data sharing. So I think that's the first important point. In getting a handle on the challenges, I think you've highlighted them, Aggie. What are the things that are going to require more in-depth discussion, including limits of care and methods of provision and scoring and documentation. One question is, it seemed that with the Diamedica that the challenges in many cases relate to consumables, and I couldn't tell whether the machines themselves breaking down, or are you simply having bits that are breaking and not replaceable, and also are you having challenges with interfaces and either obtaining and or keeping them going, and having to revert to the improvised CPAP because you don't have enough interfaces?
Thank you, Mike. One other point that I want to put it on the table, as again, us being advocates, that the shuffling of nurses, and it's happening everywhere, that the nurses who we train and are trained are moving to other departments, and the nurses, neonatal nursing should be accepted as a profession exactly as midwife is, and not moved to other units for at least a significant amount of time, so they can do care about the preterm infants. And this is something that we have absolutely tried to do for many years. And all those nurses who are here with us, I can't see their faces, but I'm sure they love what they're doing, and their presence and looking at the baby all the time, this is what they learn, and to prevent all these damages possible from CPAP. So those nurses which we are together today, I hope they will stay at least 2 years, and we make every effort that they do, not to be shuffled to other units. This profession, neonatal nursing, is a subspecialty that needs to be kept. Okay, so I think we have, we can go to the, if nobody else has raised his hand for any questions or comments, then we can move to the last part of the meeting today and getting to business to start diving into the CPAP and respiratory distress. Eilon Shani, Dr. Eilon Shani, the floor is yours.
Just a minute, it'll take me a couple of seconds, sorry. Vinil, am I able to
Yes, you should be
share my
able to.
screen?
Yes.
Okay. Okay, we'll move in. So let me put, so I'm going to go through two presentations, one after the other, and just have to find them because they all of a sudden disappeared. Wait. No. Okay, here we are. Okay, I got the presentation on. And wait. Okay, you can all see the presentation?
Yes, we can see it.
Thank you. I was waiting for one of you to answer. So just to bring you to Israel and show you, you can see a nice picture of Beersheba from the desert, and you can see the difference between the very green Ghana and the very desertic place where our group lives. And we'll start immediately with the respiratory problems. And I will talk to you about the first problem in life is that our need to breathe. Why do we need to breathe? How can we, what is respiratory distress? How we can assess respiratory distress? What are the causes of respiratory distress? How we can diagnose these causes and how to support infants with respiratory distress. Now, you all have a link to the manual, and actually this presentation runs very close to the manual itself. So you can complete it by reading, and in the end we will also send you links to videos that Venti produced, which are also complementary to these talks. Now, I think that the answer is kind of obvious. Why do neonates need to breathe when they are born? Because before they use the placenta to breathe. And once we are born, we need to do it by ourselves. And the issue is that sometimes we do have problems with breathing, and this is what we're going to talk about. Okay, we get oxygen from our breathing, we need it for our basic metabolism. And if we don't have enough oxygen, or if we don't breathe well enough, we might get some brain damage, and eventually, if it takes too long to start breathing, we may die. So usually, probably most of you know, we use the 21% oxygen that is in the air, and it is really sufficient to get our blood oxygenated. And even of neonates, after 10-20 minutes, we get a saturation above 90. And babies are pink when they're born because enough of their blood, enough of their red blood cells is saturated. Now, how can we know if a baby has enough oxygen? Something is missing here, but we will talk about it later on, okay? And let's go to the respiratory distress itself. What does it mean, a respiratory distress of a baby? It means that either there is an increase in respiratory effort or an increase in the respiratory rate. And this is to compensate for inadequate oxygen that doesn't reach the tissues, and also to compensate for inadequate lung function. There are 4 main signs of respiratory distress, and you will be able to see in the videos, you will be able to see most of them. Tachypnea is when we're breathing very fast, okay? And if a baby, a newborn baby that doesn't have to breathe more than 60 breaths per minute. Dyspnea is the word that means that the baby has difficulty in breathing, and what we see is indrawings or recessions and nasal flaring. Grunting is a very interesting phenomenon that the baby tries by himself to increase the pressure inside his lungs by closing his airways, and it increases the residual air that is trapped in the lung and enables the alveoli to be kept open. And cyanosis, which is caused by lack of oxygen in the red blood cells. And we can see a blue tongue or a blue lips, okay? And when we see a cyanosed baby, it's already a severe condition. In many places, instead of looking at cyanosis, we put a pulse oximeter, but it's still important to look at the baby and to look at signs of cyanosis. The way we assess the respiratory distress is what we call a respiratory distress score. Okay, it's called also a down score. And what actually we do, and we will have an example later on, we look at the respiratory rate and we score. So if it is below 60, which is normal, the score is 0. If it is between 60 and 80, the score is 1. If it is above 80, the score is 2. We do the same with grunting. If we don't hear any grunting, the score is 0. If we hear it without the aid of a stethoscope, the score is 2. And if we need a stethoscope, the score will be only 1. Recessions, if we don't see any, the score is 0. If they're only mild to moderate recessions, like intercostal recessions, the score will be 1. If there are severe recessions, like subcostal recessions, if we see really that the chest is going inside while the belly is going outside, which is a sign of severe recessions, we score 2. We need the stethoscope to listen to air entry and to assess if it is good, if it is diminished, or we can hardly hear any air entry. And we use saturation. And if the saturation is above 90 in room air, it's normal saturation, we score 0. If it is below 90 with oxygen, we score 2. If we can reach above 90 with oxygen, we score 1. So this is how we do the scoring if we have saturation, if we are able to check saturation. Now, pulse oximeter is very important to assess the saturation of the infant. And you have to remember this, and we can use, I mean, there are finger saturation, pulse oximeters. We prefer the ones that we can use continuously, but unfortunately, they are not always available. There is a way to assess the respiratory distress when, if we try to figure out how much oxygen we need to get a good saturation. Okay, so if there's no need, if we do see that the baby is in respiratory distress, but he doesn't need oxygen to raise the saturation above 90, it's a very mild respiratory distress. If we need about 30% of oxygen, and there is a way to check how much oxygen the baby needs. So if he doesn't need much oxygen, it's mild to moderate. If we need a lot of oxygen and we don't manage to keep the saturation above 90, it means that the baby is in a severe respiratory distress. Now, this is the list of the most common causes of neonatal respiratory distress. I will talk about most of them, not all of them. And I would like to start with the first one about neonatal pneumonia. And I start with the first one because this is probably the most common most common cause of respiratory distress in developing countries. And if a baby has a respiratory distress, he will need to be treated with antibiotics, even if we think that he has another problem also. Like if we think that it is a premature baby and he has respiratory distress syndrome, or it's a baby of an infant of diabetic mother, or a baby who underwent asphyxia, we should treat any baby with respiratory distress with antibiotics, to start them with antibiotics. Because these, the congenital pneumonia, I mean, the respiratory distress is due either to congenital pneumonia, could have been an intrauterine infection. Sometimes it is an infection that was acquired after birth. But remember that a baby with respiratory distress has to be treated with antibiotics, and then it should be checked also for other problems. Now, I'm showing you the x-rays of these babies, and you will understand eventually that mostly the x-rays are not so important because they look pretty much the same unless a baby has a pneumothorax, but then we do need an x-ray to make a diagnosis of pneumothorax, and it's very difficult to do it without it. Now, what we call wet lung or transit tachypnea of the newborn, it's common in term infant or in late preterm infant, babies that are born after cesarean section. It usually resolves spontaneously. It is probably due to some retained fluid in the lungs, and it's not a very severe disease, but some of these babies, they will need some oxygen, they will need CPAP to get over this condition. Meconium aspiration is, I don't know how common it is. It's not very common, but it is associated with babies that are born post-mature or have birth asphyxia and that had their stools passed before they were born. And what happens is once the baby has passed meconium before he was born, and if he's in distress, he may have breathed the meconium inside the lungs before he was born. Because when babies are in distress, they start breathing, and it can happen before they are born. And if they don't have any air to breathe, they breathe the liquor or the meconium. And this can be a very, very severe disease and not always treatable. Respiratory distress syndrome, it's common in preterm babies, less than 32 weeks. It doesn't mean that we don't see it in babies that are over 32 weeks. It happens before alveoli are collapsed. If you look at the videos, you will see it very nicely over there. And it is due to lungs immaturity and what we also call surfactant deficiency, because surfactant is a material that the lungs produce in order to reduce surface tension of the alveoli and enable us to breathe. Surfactant is not enough. There's not enough surfactant in the lungs before babies reach the 33, 34 weeks. So premature babies, most of them do have some degree of respiratory distress syndrome. Pneumothorax is not an innate condition. It's usually a complication. It's a complication of babies that are either need some positive pressure ventilation or put on CPAP or have meconium aspiration. And sometimes it also happens that spontaneously to babies with respiratory distress. So what you see in this picture, the pneumothorax is a condition when air is trapped between the cage, the thoracic cage, and the lung. And the lung itself cannot, air cannot go into the lung. This is how we see it in an X-ray. This is how it looks like. You see that the lung is collapsed, and if it is not treated, usually babies may die, and it can be easily treated with the needle aspiration, but you have to make a diagnosis which is not straightforward in most places where you don't have a portable X-ray machine. And if a baby is not stable, it's kind of impossible to move him to a place where he can be X-rayed. So you have some of the answers to this question. How can we know the cause of respiratory distress? Well, it's not easy if we don't have access to an X-ray. It's not always easy, even if you have access to X-ray, because you've seen in the X-rays that I showed you that babies with transient tachypnea or RDS or pneumonia may have the same X-ray. So we should take a careful maternal history, and part of it is to check if the mother had fever, if she was sick, if it was a cesarean section, is the baby premature, and we should examine the baby. The smell of the baby is infected, somebody that have a bad smell. We should listen to air entry. We should also listen to the heart, because maybe it's not, it's quite rare, but some of the babies with respiratory distress, their distress can be due to a cardiac problem. Okay, some of the babies with respiratory distress, their distress can be due to anemia. Okay, a baby with the jaundice, for example, the jaundice may be due to RH incompatibility that caused anemia, and then he starts having respiratory distress. But most of these babies have either pneumonia, either some respiratory distress syndrome or transient tachypnea. And these are the main causes of respiratory distress in a baby. How do we treat respiratory distress of babies? So first and foremost, we should give them antibiotics. It's very important. And it's also very important to know what kind of bacteria you have in the unit. And I know that more and more you have blood cultures in different units, and it's important because then you can focus on the antibiotics that can really help the babies. We need to monitor these babies. It's important to be able to have continuous saturation of babies with respiratory distress, and it's not a luxury to have a pulse oximeter. So we can tell you that not very long ago we didn't have pulse oximeters for all the babies, and we would move the pulse oximeters from one baby to another, which is feasible if you don't have enough. But to have saturation of babies, you can decide if a baby needs to be on oxygen, needs to be on CPAP, or you can stop the treatment. The respiratory distress score is also very, very useful in assessing babies. And you will see in the next talk that we can use it in order to decide when to stop CPAP on babies. So oxygen as needed, face mask, nasal prongs, oxyhood, and CPAP are used to help babies with respiratory distress. this is the respiratory distress score, and you can see that in case you don't have a saturation, you can use the cyanosis to check the baby for cyanosis. And lastly, the CPAP. So can we prevent respiratory distress? This is an interesting question, and actually sometimes we can prevent respiratory distress. Giving antibiotics to mothers who had some premature rupture of membrane, we may treat sepsis and pneumonia before the baby is born. Giving prenatal steroids to mothers who are going to deliver prematurely, it decreases the severity of respiratory distress syndrome in premature infants. And to do a cesarean section on time, which is very tricky. It's not easy, but sometimes you may prevent babies born with asphyxia and meconium, and you may, they will just be born healthy, and you may prevent asphyxia and meconium aspiration. So this is the end of the first part of respiratory distress, so me talking about respiratory distress. And if there are any questions, maybe I will take them now before we start the session on CPAP.
May I just make a short comment?
Sure.
You mentioned antibiotics, but I would place in front of antibiotics the treatment of hypoxia, because hypoxia is an emergency which has to be addressed immediately, whereas antibiotics is something which you prepare and you inject, and that all this takes time. But you should never leave a baby hypoxic. So having a baby with respiratory distress, question number one is, does the baby need oxygen? If the baby is cyanosed, he needs oxygen, you don't need even an oximeter. If you are in doubt, you put the oximeter on, you see that he's hypoxic, his saturation is less than 90, you give him oxygen. I think this is the first emergency step which we have to emphasize immediately. And so this would be my comment, not to wait with oxygen. If he has respiratory distress, then he may very well be hypoxic and in need of urgent oxygen. That's my comment.
Mickey, thank you very much. Sometimes things that may be clear to us that you don't leave a baby hypoxic are not clear to everybody. And I definitely agree with you that if we see a baby that we think that he might be with respiratory distress, we should help him, give him oxygen, give him some kind of support, and then go to look for other things, because this is emergency and this can be done very quickly.
I would really want to warm up our dear students, the nurses and the residents who are listening to us, to stop being shy and ask questions. This workshop is for you, and you have all the opportunity to ask any question that you feel like. So please do so.
I think, Agi, that shyness is congenital in Ghana, and but I agree that people should really be open. I mean, this is for you, and if you have any questions, it's now the time. Though you do have your physicians at the MBUs that are very knowledgeable, and we know them and we work with them for a long time already. But please do ask questions. Ashura, you raised your hand.
Yes, I have a question.
Sure.
Yes, so in our units, most of the time we tend to put babies on oxygen. For example, sometimes we have babies with very fast breathing, let's say 80s. in 80s, but the baby saturating all right. So for such baby, do we have to put them on oxygen, even if their saturation is good, or we shouldn't? First,
What do you think?
First, we have been giving oxygen, but I want to make sure we are doing the right thing.
No, I think that maybe you understood from my presentation that oxygen is a drug. If it is not necessary, don't use it. Also, I'm not talking about the cost of oxygen, but if a baby is in respiratory distress, and this is why, and I will talk about it in the next session, that you may decide that you want to put a baby on CPAP because he's got a respiratory distress score that is above 4, but he doesn't need oxygen. Because oxygen is a drug, especially in preterm babies, it may be deleterious and cause some complications. So you don't have to use it. Sometimes baby needs some support, but usually if a baby has fast breathing, he doesn't need oxygen if his saturation is above 90. You will not help him by doing this.
Okay, thank you.
Elon.
Yes.
I think it's a warning that the baby maybe within an hour or less may need oxygen. And we have to be very careful with this baby. Okay, if we don't give him oxygen, we put him on an oximeter. And maybe after 1 or 2 hours, he would deteriorate and need oxygen. So it's definitely a warning, even if you don't give. And I agree, not to give, it's not necessary. He has to be monitored. And very important to me.
Another thing that giving oxygen to such a baby will not prevent his deterioration later on. Giving CPAP to such a baby may prevent his deterioration because giving CPAP will keep his alveoli open, and it's a way to prevent deterioration and even prevent the need of oxygen.
If you have enough machines.
Well, maybe these are the babies that can use bubble CPAP, like homemade bubble CPAP. If you don't have enough machines, it can give them, but the problem is that you cannot use the bubble CPAP, the homemade bubble CPAP without oxygen because you don't have air cylinders.
I wanted to use the opportunity and just reflect to the talks that were presented before by Ashura and Rita. It is very important that those special care rooms that you were talking about keep in babies who need close monitoring. And I understood how, and then because you do have limit of the CPAP machines, you have limit of the oximeters, so you have to have very clear indications for monitoring babies in these special care rooms. And the idea of having rooms of different levels of care, we discussed that in the past. It's very important, and will give you opportunity to follow up these babies who are breathing fast, and you have to understand which way they go. Are they going to improve or are they going to deteriorate? And to discharge from the special care room babies who do not need the special care room will enable you a more close follow-up of these babies. And I saw that this concept is practiced in Confanoce, and it's practiced in Suntreso and Kumasi also. I remember how we did put phototherapy of the term babies outside by moms and do it bedside, so still with mom. It's good and safe and enables less congestion in the room. So to be able to monitor. So I just wanted to reflect back to what you have told us and keep these rooms high level acuity and using your equipment the best criteria you can. So yes.
I think I will go to the next session before people are getting too tired.
Yes,
Makes sense?
makes sense. Last 20 minutes or 15 minutes.
Okay, it won't be very long. It's just to give you an idea what happens in Beersheba when there is a lot of rain. There is one river that is usually there no water flowing in, and this was a couple of years ago. It filled up with water. It was very nice to see, but you see that the surrounding stays gray and it's still a desert. So I will give you a short session about CPAP, which is an acronym of continuous positive airway pressure. Not in this baby is getting only an oxyhood, is without CPAP, but he's in respiratory distress. It's you can see the movie in the link that Venti will provide later. Oh, I don't see if you, can you see the film? No. So I will talk a little bit about what is CPAP, how does it work, how it can help babies, who should be treated with CPAP, what are the dangers, how do you take care of babies in CPAP, a little bit about nasal cannulas, feeding with CPAP, and weaning from CPAP. And it will be really very short on each one of the topics. So I already said the CPAP is a continuous positive airway pressure, and it is a method that is used to help in cases of respiratory distress. Now, this diagram is a very, very basic diagram of CPAP, and they use it when you do homemade CPAPs. You have an oxygen or a source of air somewhere that you start, and then you have a tubing, that one side of the tubing is going to a water reservoir where you put the tube just below the water level, and the water level, the length of the tube inside the water is what is important to create the pressure. The other side of the tube is going to the baby's nose. And this is what creates a pressure that keeps the alveoli open. You have to remember, CPAP is not a cure. It's a way to help babies with respiratory distress. And it works pretty much the same as the grunting phenomenon is working. But here, instead of the baby that needs to do the grunting, you have a machine that helps him by giving a continuous flow of air at controlled pressure. So usually it helps in inspiration, and when the baby is expirating the air out, it doesn't expirate all of the air, and it prevents the collapse of the alveoli. So you can see here open alveoli, and you can see here what happens when they're collapsed. And it's more often, it happens more often when the babies don't have enough surfactant that alveoli collapse. So it's one of the best ways to treat babies with respiratory distress syndrome. So already answered, I think, this question, and it keeps the alveoli open. By keeping the alveoli open, you have an improved gas exchange. And you can see that babies on CPAP, if the CPAP is working well, you see that the respiratory rate decreases. The babies consume less energy because they have to work less and they feel more comfortable. So who should we treat with CPAP? Babies with moderate and severe respiratory distress score and the following conditions, which means that first, and I will go again through the respiratory distress score, but babies with either respiratory distress syndrome, pneumonia, meconium aspiration, and transient tachypnea of the newborn, these are the babies that that are eligible for CPAP if the respiratory distress score is above 4. Okay, so this is again the respiratory distress score that we use, and I will use it again with an example. So since we just talked about it, let's go further on. So just think of a baby that is brought to the nursery from the delivery room. He cried at birth, but soon after birth, the midwife noticed that he was grunting, but his color was pink. The baby was taken to the special care nursery, put under a radiant heater, and given oxygen by neonatal catheter at a flow of 1 liter per minute. And then you come after a couple of hours and you check this baby, okay? And he has a respiratory rate of 80 breaths per minute, which put him over here, okay? He's just in between, but it's not over 80, so you score 1. The saturation is 85 with the flow of oxygen that you've given with the nasal catheter, okay? I'm sorry, but it should have been somewhere over here, okay? You got 2. As to grunting, it can be heard when standing near the baby, so it scores 2 for the grunting. For the recessions, they are moderate, and the air entry is good, okay? Overall, you can count 1, 3, 4, 0, and another 2 is 6. So your respiratory distress score is 6, and this baby may be given some CPAP, it could help him. Now, there are babies that we don't want to treat with CPAPs. A baby with pneumothorax, CPAP will not help him, okay? On the contrary, babies with congenital diaphragmatic hernia, which is very rare, but CPAP will not help him. And baby with necrotizing enterocolitis, these are babies that have a distended and red abdomen. CPAP may be dangerous in these babies. And sometimes we have to remember that we cannot help all the babies. There are babies where it's not completely obvious if we can treat them or not. So if you write here babies below 1,000 grams with severe respiratory distress score, is not because CPAP cannot help them, but it is because they're most likely very immature lungs. And these are the babies that we don't succeed in helping them only with CPAP. If we don't have surfactant replacement therapy, if we don't have a respirator to help them, CPAP will not help them, it will just use the machine. Babies with severe birth asphyxia, they're not breathing, and CPAP will not help them. And babies that are not breathing, again, unless it is what we call apnea of prematurity, that they need something to remind them that they need to breathe, CPAP will not help them. But babies with apnea of prematurity, not babies that are not breathing because they're septic, CPAP may help them. So if they're septic, if they look very bad and they're not breathing, CPAP will not help them. It will just let them be alive a little bit more, but it will not help. So we have to decide sometimes difficult decisions as to which baby to treat or not. I think that Nana talked very nicely about the dangers of CPAP, and you showed real pictures, and this because these pictures are taken from the internet, and you showed real pictures of the nasal septum damage, which is something that should be monitored all the time in order to prevent it. Pneumothorax is also a dangerous complication, and again, a baby should be checked and monitored all the time to prevent pneumothorax. We prevent it by seeing that we don't get that the pressures that you use are appropriate. Okay, sometimes they have abdominal distension because they're not able to breathe all the air that gets into their through their nostrils, and part of the air they swallow it, and it causes abdominal distension. And you can see in this baby that not only has a pneumothorax, but also his belly is full of air. So if there is a sudden deterioration, it means this is a dangerous sign. And first, you have to see if the baby is breathing. You have to check if all the connections are secure, and we will talk about the machines in next sessions. You have to see that the nasal prongs are in place and patent. And you heard from Nana that sometimes they're filled with secretions. You have to empty the stomach. A baby with an enlarged stomach, because it's full of air, cannot breathe. And you have to empty the stomach. And eventually, of course, you have to listen to the lungs with a stethoscope to see that there is equal air entry to both lungs. Now, as to taking care of babies on CPAP, I think that Benil had showed you, if you need to check these babies and you need to write down, you need to have forms in order to be able to follow up these babies. They are very sick babies that are on CPAP. They need close attention, and a nurse needs to be in the room where there are babies on CPAP. So these babies are cared for under radiant heaters, and very small babies sometimes are cared for in incubators if you're able to take care of incubators, but radiant heaters are enough. Oxygen saturation should be monitored continuously, and all the tubes, the connection, the bubbling in the CPAP, the vital signs, and the NG tubes should be decompressed every 2 hours. By doing so, you will be sure that you take good care of the baby. It doesn't mean that you cannot go every now and then to check the baby, but if you write down your notes every 2 hours, you're sure that you checked everything because you have a checklist. And every 8 hours, the nose should be checked and the nasal prongs should be moved a little bit in order to ease the pressure on the nose. There are 2 nasal cannulas that are used for nasal CPAP. There is what is called the RAM cannula, which is more comfortable, and there are Hudson nasal prongs that maybe give better CPAP delivery, but they're much less comfortable for the baby. And each unit is using the nasal cannula that is good for, that they're used to use. Can we feed babies on CPAP? Yes, we can. It's also very important to feed babies on CPAP, but it's very important to check the residue to see that they're able to pass the food on after the stomach. If there is a large residue, we should stop feeding for a while. Sometimes we should put babies which have a severe respiratory distress, we should put them on IV fluids. And very important, we should decompress air from the stomach at least every 2 hours. Actively to decompress the air from the stomach, it's important because it tends to fill in. How do we know that we can wean baby from CPAP? If we check the respiratory distress score, once it's below 5, it means that maybe the baby doesn't need the CPAP anymore. You can keep it for a couple of hours more to see that he's really you don't stop the CPAP the moment the baby is below 5, as a respiratory distress score below 5. You can wait a little bit, but if you see that he's below 5 for like 8 hours or so, okay, you can wean from CPAP, okay? And you have to see that the oxygen requirement is below 30 and the respirations are back to normal. Usually we continue babies on nasal prongs, we give them oxygen with nasal prongs for a while until we see that they don't need any oxygen anymore. After weaning, the babies should stay in the special care unit and be monitored for at least 24 hours. And you have to remember that some of the babies need the CPAP treatment again. They may return to CPAP treatment if we see that the oxygen requirement increases and if we see that the respiratory distress score also increases. So this was very short on CPAP. And again, if you have any questions and comments, it's now the time.
Elon, you have a question in the chat. Can babies on
There is a
CPAP?
question saying whether can babies on CPAP be breastfed? Alberta asked.
I think it's a very good question. It's not easy. We prefer to keep the babies on NG tube because most of these babies are in severe respiratory distress. And when the baby is fighting for breathing, maybe it's better to put them on NG tube because they need their energy for breathing. And breastfeeding a baby which has a respiratory distress score over 4, it's kind of telling him, okay, not only you have to breathe now, but put part of your energy into feeding. So if you can express breast milk and give it by NG tube, it would be much better for the baby.
I think there is a big risk of aspiration, simply. I wouldn't risk it.
Alberta, what is important, sorry, Mickey.
No,
what is important that kangaroo mother care can be done with CPAP. And this needs probably a hands-on workshop, which we cannot do it online. Maybe we will prepare a small clip for it, maybe, but with good nursing and good monitoring, a baby can be put on kangaroo mother care, so you still can improve breast milk production, and then the mom should express her milk, and then the milk given by NG tube, and continuously encouraging the mom that as soon as the baby will be getting better, the baby will go back on the breast. But at the acute stage, when the respiratory score is high, direct oral feeding can be inappropriate. And remember that most of the babies, babies are preterm and they might not be able to suck very well. So that's not a good way to feed during respiratory distress.
Agi, I think that Nana is here and she can comment on this, because the study that they did, they put the babies very, very quickly on kangaroo mother care. And I believe that they kept them on NG tube, but the possibility to do kangaroo mother care on baby with CPAP is really, it's an option. And it's also a good option because it helps to express more breast milk. Nana, can you comment something about it? Well, she's here, but she's not commenting, so.
Okay.
Elon, I wanted to mention something.
Sure.
I think, Elon, your presentation is really crystal clear, and I would make photos of your slides and put them on the wall in the intensive care room. They are really very nice. And I have just one comment on your first slide. If you can go back to the first slide, which shows the baby who was getting oxygen 1 liter through a nasal catheter. I think it was.
You're not talking about this one.
No, the one where it says 1 liter through nasal catheter.
Okay, here.
Yeah, I think. No, the next one, because it has got a saturation of 85. Yeah, this one. I think the reflex of some nurses, at least in the past, was to increase the flow. Saturation 85, and he's getting just 1 liter, so let's give him 2 liters or 3 liters. And I think this is something which we should forget about. I mean, we don't give more oxygen than 1 liter per minute. And if it's not enough, as in this case, it's clearly he needs CPAP, it's very clear. So I think one should not give large amounts of oxygen with nasal catheters. This is something which is not helpful, it is even detrimental. That's all.
Okay. Thank you so much for the comments and for the lectures. We will have at least 2 more sessions on weaning from CPAP and complications on CPAP and babies deteriorating on CPAP. So we will have more and more discussion around the issues presented by Elon. And if there is no more question, we can say thank you for everybody.
I think
have a
Alberta
que-
has a question.
Yes, okay. I want the faculty to stay on the Zoom after the students leave. Who has a question?
I have a question concerning decompressing the stomach during CPAP. Once you start doing NG tube feeding and you want to decompress the stomach, sometimes it's the residue that comes out. So I want to know what other ways you can use to decompress the stomach.
So I think if you get a residue, it means that there is not a lot of air in the stomach. I mean, you cannot decompress, you can only decompress the stomach. If the air passed to the intestine, you cannot decompress them. And this is why it's important to do it every 2 hours. So there's less air going into the intestine. Now, when you do have residue, you have to check up how much residue you have. If you have too much residue, it means that the baby is not able to digest the milk and you have to stop feeding him and put him on IV.
If I
Does this
understood
answer
you
the question?
correctly, if you have, when you aspirate the air and you get some milk also, you can put back the milk if it's not a big quantity, I mean, and you still can decompress from the air and continue feeding. So this is a technical challenge that if you do it every 2 hours, then probably the air will not propagate to the small intestine and will not have this abdominal distension that sometimes you can get from the CPAP.
Okay,
And
we do
yes,
have another question, like a follow-up question. If we have to open the feeding tube after feeding. Now, we prefer not to open it immediately after feeding, so the milk will not go out immediately. And this is why we keep it closed for 2 hours and then we reopen it. In some places, you keep the feeding tube, you keep it up in the air, so the air would go out. But still, for at least half an hour or an hour, I would keep the NG tube closed.
If I understood the question correctly, there is no indication to leave the NG tube open to a bag prior or at any time of feeding. The baby have the NG tube is connected to the syringe when the baby is eating, and then you close it and you just aspirate the air before the next feed and you go on feeding the baby. And of course, you need to think about whether did the baby have stool, and maybe you can, or you want to help a little bit of with a glycerin. Sometimes small babies have difficulty in having stools, and this way you also can get rid of anything that is stuck in the stomach. So no need to open, just to drain the stomach. Okay, did we answer your question? Doris, did we answer your question? Okay, I don't hear.
She may be on mute. That's why you can't.
No,
Yeah.
there is another question from Francesca about the residue checked for babies on CPAP, done specifically within 3 hours or whenever feeding. You check whenever you feed, and babies on CPAP, it's better to feed them 2 hourly, so you can feed less quantity each time, and they don't have a lot of milk inside their stomach. So you don't, if you feed every 2 hours, you check every 2 hours. If you feed every 3 hours, you check every 3 hours.
I would have one more little comment on the residua. In the literature, there is a lot of argument whether I think the newer articles say don't check residua at all. But I think you have to think about also what kind of residua you have. If it's nice milk and the small quantity, you have to continue feeding. Very often nurses stop feeding too many times because they get this residua. So really, if the baby is well, good perfusion, looking not sick, not having necrotizing, like a well-looking baby, it's very important that you really consider not to stop feeding in your setup. Of course, when you have do not have parenteral nutrition and you have little other ways to get calories, you don't want the babies to be not given enough calories. So again, be very careful about when to stop feeding and when to continue. In a well baby, a small amount of residua is okay to have before the meal. Green looking, yellow looking, bigger quantity of residua, bigger than the meal itself, and a sick looking baby would be something that you worry about more. Okay, now the students have more questions. If a preterm baby is less than 1,000 grams and the respiratory distress score is more than 5, what form of support can we give them to improve upon breathing? No discarding of the residua if it's looking good.
Yeah.
What was the question?
No. Alberta asked again if we discard the residual or you push it back. We push it back if it's not too much and if it looks good. Too much is more than 50% of what you fed the baby. Now, Kofi, what you ask about babies that are less than 1,000 grams, it's a difficult question. Each unit should decide for itself which babies you take care for and if you can take care for these babies. If the only thing that you have is CPAP, many of these babies will not survive. And, sorry? Binil, can you mute? Okay. So again, what I'm saying, it's a problem. If a baby with less than 1,000 grams have a respiratory distress score of 5, or if it's different from a baby who has a respiratory distress score of 10. It's different if this baby is a 35 weeker, which is very small for gestational age, or if it is a premature baby of 24 week, that even here with the sophisticated machines, we don't save more than 50% of them. So it's a discussion that you have to make in your units and to decide what you do. We'll be happy to discuss it with the doctors of the units, but I think that it is a very important and difficult question.
Okay, I think that I would encourage anybody else having more questions, just please forward it to Rita and to Ashura, and we promise to answer every question by mail or by some other means of communication. Maybe the beginning of the next meeting we can answer if it's a question that is a good something good for all the group. So please write down your questions and don't forget about them. They're very important and very good for your day-by-day practice. So I guess if it's okay, Ashura and Rita receive the more questions, and I promise to take care of the good responses and reference to literature or whatever is needed. The issue of the limit of care is something that we will decide to discuss as a faculty and still see how we can support decision-making in your department. And that's definitely a very complex topic to discuss. So I guess if it's okay with you, it's very late. We should say goodbye for today. And thank you for everybody for participating and asking questions. And please, the faculty, please stay for another 5 and 10 minutes after. Benil, you wanted something?
No.
No housekeeping. Please be on time next time, so everybody is connected, and we can start in time next time. So thank you so much, everybody. Really a very good meeting. Thank you so much. So please, faculty, stay, and all the rest of the students, good night.